hello everyone, all of our amazing participants, all of the illustrious speakers that we have here. This is our second webinar in the Demystifying Gender series. This webinar is about gender affirmative care in children and adolescents, which is why we have an amazing specialist panel here who would like to talk, who would be we would be more than happy to hear about them talk about gender affirmative care in kids as and when they are growing up, when they need to be reaffirmed, all of these things too. Before we begin, I'd just like to stress that today is 15th August, which is 75th Independence Day for India. It has been 75 years since we got free of the colonial rule, but there are still a lot of things plaguing our society in general, and this is one extremely important issue that we have sat down to discuss with. And before any without much ado, let us get right on with it. So we have these amazing hosts. The people who are hosting you all are basically Querencia, in collaboration with the WHO Collaborating Center for Pediatrics Department in LHMC, the representative of which Dr. Pemde is also here. We have Athi, and we also have, well, Lady Hardinge Medical College, which is basically our home ground, all of us right here. And these amazing speakers in our panel, we have Dr. Kale Knutson, we have Dr. Wallace Wong, we have Dr. Jenna, we have Mr. Atul, we have Dr. Harish Pemde, we have our amazing moderators, that is basically Dr. Sanjay Sharma, who is basically the Karta Dharta of all of this. And we have Tia. Tia is an amazing fashion designer, and Tia is also going to be co-moderating the session with me. So Tia, we would be glad to hear something about our speakers and something about Athi. So take it away from here.
Oh, absolutely. So hi everybody. Today's webinar is a really special one because we are looking at pediatrics, and pediatrics is the branch of science that's usually going to be the sort of first stepping stone between your primary healthcare providers and your individuals who are seeking these cares. And the kind of subset of population we're looking at addressing today is people who experience any form of gender dysphoria, any gender non-conforming and trans individuals particularly. I think we have experts from all of their fields that have been gathered here today. And as we know, WPATH is the final word in transgender healthcare. They quite literally wrote the book. And I'm very glad that you sort of threw this to me because as somebody who is studying medicine, Prachi, would you agree that something like this, these kinds of conversations are really important to be had because they are missing from the curriculum?
Exactly. These conversations are never anything that have been taught to any of our seniors in 5.5 years of medical education in India. I'm not sure of how that works outside India, for which we have Dr. Gale, Dr. Jenna, Dr. Wallace here, who could tell us something about sort of how these things should be in places where they really do teach all of these things. But we are here talking about an Indian perspective, the fact that the word transgender is still an umbrella term in India. And the only people that we talk about are the Hijra communities and the Kinnar communities. And all of those still do not do justice to the wide variety of the entire spectrum of people that exist in India. Is why I feel conversations like these are extremely important. And we being medical students, the people who will be the future healthcare professionals will be the ones who will essentially affirm this kind of care into the younger generations, which is why we needed to have this conversation with the experts. So,
and since we are talking about conversations, the very first thing that we are presenting to everybody is a conversation between Dr. Harish Pemde and Dr. Kale Knutson. Dr. Kale Knutson is the co-chair of the Global Education Institute and is part of the WPATH. And we already know Dr. Harish Pemde. And Dr. Harish Pemde is part of the WHO Center for Collaboration and has been instrumental in the setting up of these webinars. So, sir and ma'am, if you would please like to take it forward. Just go ahead.
Thank you, Tia, and thank you, Prachi. And dear friends, good evening, a very good evening. And I am really happy to see Prachi moderating this. She is a very young medical student from Lady Hardinge Medical College. I am really very, very happy to see their efforts in the form of Querencia, and Dr. Sanjay is moderating and guiding them to develop further. Dear friends, I am also very happy to see that this program, this series of webinars is making real ripples in the pediatrician, among pediatricians. And I should welcome, and I welcome Dr. J.C. Garg, who is the current chairperson of Adolescent Health Academy of Indian Academy of Pediatrics. Good evening and welcome, sir. I also welcome some of the very senior pediatricians who have joined today as just to listen to people and just to understand the subject. I welcome Dr. Rashmi Dwivedi, who is the former HOD of Pediatrics from Bhopal Medical College, a very senior amongst us, teacher of many of us. Dr. Nedu Chelian is another person who has joined from Chennai. He was the editor-in-chief of Indian Journal of Practical Pediatrics for many years and a very respected senior pediatrician from Chennai. Dr. Kedar has joined from Aurangabad, and Dr. Preeti Galagali has also joined. She is also a former chairperson of the Recent Health Academy. I welcome everyone, and with this special mention of these senior people who have joined today. And I find that we are now ready to take this subject further amongst pediatricians at least. And we shall go to other specialties also in the future, in the near future. So friends, today's webinar is based on the pediatrics and to understand how the child goes through these various changes during early childhood and during puberty, and how and when this gender manifests and in what way it manifests. And it is very, very important for all of us to understand it, for all healthcare providers to understand it. See, when you make people aware, those who are practicing, then you are making aware only those people. But when you bring some changes in medical education, that becomes long lasting and forever. So today's discussion with Dr. Gail is about including gender topics, gender issues in medical curriculum. So Dr. Gail, welcome to the program. And I also welcome other participants, Dr. Wallace and Dr. Atul, the other faculty members. Dr. Gail, please tell us why it is so important to include the gender issues in medical curriculum. And I would go further, not only for MBBS, but other medical related curriculum like for nursing curriculum, which is a very, very important thing. Nursing support is very important, rather more important than doctor support. Why it is important to have these things in curriculum? Dr. Gail, please.
Thank you, and thank you for having me today for the webinar. I'm part of the faculty at the University of British Columbia, and we have sex and gender as part of our curriculum in year 1 and year 2, and also in year 3 and 4, people are able to take electives in this area. And I find that people or the medical students are much more comfortable talking to people about their sexuality, also about their gender. And then they're much more likely to ask people those questions when they're seeing them in residency and also in practice after they graduate. So I think it's really important that earlier that we introduce this in the curriculum, the better. And before we started when we were meeting before the webinar started, I was saying that WPATH has been involved for the last 3 years co-leading a seminar with the American Medical Students Association. And this has been very successful. We've had it once per week for 12, 14 weeks. And we've run this for the past 3 years and had medical students join from across North America and Central America. And it's been very successful. So that's maybe something that that we'd want to partner with T and the different members here, Lady Harding, to have a similar series.
Okay. See, for including any subject in medical curriculum, it's a long, arduous task. And we need support from everyone, from international agency, from national groups, from activists, from everyone. So that will be required. Taking this issue further, currently we are having a competency-based curriculum for MBBS and for post-graduation courses also in India. And this formally started about 2 years ago with 2019 batch of MBBS. I don't know whether Prachi belongs to 2019 batch or not. Okay, maybe the juniors are undergoing through this. So to know for everyone that what competencies are required to practice gender affirmative care or gender friendly care as a healthcare practitioner, maybe nursing, or as a medical practitioner doctor.
Well, we base them on competencies that are found in the medical curriculum within North America. And there's 4 competencies: caregiver relationship, content knowledge, interdisciplinary practice, and also professional responsibility. And it was a really interesting exercise for us at WPATH about how we went about looking or trying to have these competencies, and that we gathered people from all the different continents that were specialists in terms of curriculum planning within their universities and medical schools. So these 4 competencies are agreed upon across people from different continents.
That is there, and actually in curriculum we need to define what competencies a student need to learn, what they may be aware of, what they must expertise, what they should demonstrate. So few of them maybe just first of thing it comes the respect for the patient. If we respect our client, if we respect their decisions, if we respect their desires, their positions, then everything else will come through following that. And definitely we have to practice like making a rapport and then going through it, through those counseling steps. And if we find, not because of personal prejudices, but if we find something is not correct as the society believes or as the science believes, then maybe we may need to change in that person. But science is changing fast. And I would like to confess that most healthcare providers do not understand the subject of gender affirmative care. But I am also very happy to note that people are ready to learn about it. In the same way, Government of India is also showing a way, having adopted some legislation regarding this, having decided to make a center of excellence in All India Institute of Medical Sciences in New Delhi, and also having decided that similar center of excellences will be made in every medical college of India. We have about 600 medical colleges in the country. So this time will come, certainly with the activism of ATHI, WPATH, and many such organizations, and Curentia, and we can count on Lady Hardy Medical College also on that, certainly. So WPATH is a world organization. So how WPATH can help or is helping in establishment of these center of excellence? If you can tell something about WPATH and its role in such centers.
Sure. So WPATH is an organization that it's a nonprofit organization that was formed in 1979. I heard the other day that we are 3 members short from 3,000. So we're almost at 3,000 members. And one of our activities or main activities now is the Global Education Institute. And we've trained over 5,000 people over the last 2 or 3 years. And over the last year or so, with the COVID pandemic, we have switched to online training. And so we will continue to do this as we see how the health situation is going, or the pandemic situation. Our trainings have been very successful. We have a foundations course. We also have advanced courses in medicine, in mental health, in child and adolescents. We also have a course in ethics. And what we're doing is adding more courses as people come forward and give us ideas in terms of what they would like to see We also have a certification program, which is a member benefit, and people are also welcome to join that program. And there's been many people of the ATI board that have taken the GI courses and have become certified members. And we have Dr. Sanjay there as one of our main people that has been leading everyone.
Thanks for telling about the path. Actually, when this issue of medical education comes, we can divide into broad categories. One is in-service education, means those are already qualified their medical degrees and are now practicing. Another becomes pre-service education, where students are taught about a subject. So the curriculum issue is for those who are still a student or who will become a student in future. But this in-service education is also very, very important because we need to make aware or make them friendly a large number of practitioners in the country. Okay. So such courses are very handy, are very, very important. Such courses, such webinars, such CMEs, and after establishing those centers of excellence, I think they will surely benefit from WPath because we already have some similar courses. They will also develop some similar programs, and Government of India has its own portal for such online programs, which are free, available to every citizen of the country and maybe from outsiders also. And institutions like Indian Academy of Pediatrics also has a very strong component of training and very strong component of CMEs and conferences. So this issue will certainly come up for education and making people friendly of Indian Academy of Pediatrics. But current time is for strong data. Everyone asks for the data. Even I would also wanted to ask for data from Dr. Sanjay Sharma when he says about 15-20% people are affected by this issue. This looks a quite big number to me. Still, I can't believe it. But yes, for people like me and for any other people, we need a strong research component. And we need a strong research from India or Indian subcontinent because we have the Indian subcontinent would have the largest population in the world from this particular area. So how important is the research and how should we go about collecting data and having our own evidences that yes, things exist and their needs are this. It is us we need to understand and change ourselves to provide those needs.
Well, actually, just yesterday, the European Professional Association for Transgender Health just finished their conference. It was from the 12th to the 14th. And EPATH is one of the divisions of, or one of the areas of WPATH. It's a European area, and they were the first people actually to start the big data sets. You're asking about the data and about the research. They were really the people that started it. And the other now the US in the last about 5 years has started to make these big data sets and big collections. And so we would really like to partner with the people in India and also create these big data sets to have the numbers that you're looking for. And because now that we have people we can learn from people in Europe and also people from North America, and we have this expertise that could come together and work together as partners to create this big data set across the Indian subcontinent, because you have the largest number, as you were saying.
Yes, so I would rather request Turantia people also, through their small research, as a student research, they can make a big difference. Similarly, they can influence and invite medical students from around the country. If we can have just few projects to understand whether this exists, how much does it exist, what are the various issues, and that will be eye-opening for all of us because we need that strong data from India. Some may definitely be existing, but yes, people are not very well aware of those things. And I'm sure one more thing is happening in the Indian Academy of Pediatrics. We have made our own ethics committee, which will be functional very shortly, Dr. Sharma. And that is kind of among the first for any academic organization in India to have its own independent ethics committee. That is also going to promote research by those who want to do research and do not have access to ethics committees, as many of our members of Indian Academy of Pediatrics, or rather majority of them, do not belong to various institutions. They do their own practice, either clinic practice or a small hospital practice. But many of them want to do some research. And doing this kind of research is also very, very important for them, supporting them. Indian Academy of Pediatrics has taken this step. Rather, I am the member secretary of that committee. So still we have some time for this session. I would request if any of the persons who are attending here or the senior pediatricians who are attending, if they want to make some comment or ask some questions, they are free. I think we have about 4 or 5 minutes for this question answer session. If people are there, or even the students, if they want to ask some questions about it, they can share there.
Sir, is it okay if we had 1 or 2 questions that people were really eager to know about? Is it okay if we ask them?
Yes, we can take up right now.
Yes, sir. So, this question we'd love if Dr. Gale could answer. Ma'am, we wanted you to elaborate about how to educate the primary caregivers, like the parents and the teachers, because they need to understand how to create a safe space, since they are the first people to interact with the children. And in India, like we said, there are no specific guidelines as to how to go about doing that. So, ma'am, we would love it if you could elaborate on that.
I'm actually going to pass that question to Dr. Wong and also to Dr. Slovis, because that's part of their talk. So,
I think that oh, go ahead.
Yes, you can speak, please.
Oh, okay. Yeah. Yes. That is always a big part of it. Not just I think that in Asia or other country, but it's also in North America too. So we do find that sometimes the parents they would have many different questions about, my kid just came out as transgender or have gender identity concern. How are we going to be able to help our kids? And should I support it, or should I punish the behavior so that my kid less likely to be transgender? So I think that's very important. Number one, education for the parents is very important, but a lot of times the education may turn to primary care for those answers. So I think having that education being provided, primary care provider, will be very crucial, because a lot of times that parent, they have their working trust relationship with their primary care provider, able to go to the first stop to get the accurate information, how to support the kid and how to provide the care that they need to foster healthy development, help the kid learn about the gender identity, and be able to have relatively development to learn about the gender identity will be very important. So I think that will be that I would love to see this happen more established in the future.
Okay, there is one question Dr. Rashmi Dwivedi has asked about the objective of this conversation. And I think Dr. Sharma would be the best person to answer this question. What was the objective of keeping this conversation? And next part of it, is it necessary only for medical students? Then why not sensitize from the school? So I would like to answer the second part, but Dr. Sharma, can you answer the first part of it?
Yeah, so thank you. Firstly, thank you for that very important question. And I'm sure ma'am has asked this to, highlight and underline the importance of this conversation. It is so important that we understand why medical education needs to expand to include all human forms. We can no longer ignore, a subset of normal people who we need to treat or give care, not cure, care in places which are traditionally designed for giving cure. We also needed this conversation, and that is why we started with this issue of having the co-chair of Global Education Institute to tell us about the core competencies, to tell us about the need for it to be taught. Because once it is taught, then the students will learn. And once the students learn, it will come into practice. And yes, we have to start somewhere, and the best place would be the medical colleges to start. Automatically, we'll have people who are training people to become doctors to pick up this subject even in schools and feed them up. So we are, so to say, if I use some military language, targeting our intervention very critically to the medical students. Because when we talk about knowledgeable people, we have doctors and we have teachers. Yes, if my child is in trouble, then I would ask opinion of a doctor. If the doctor doesn't know or doesn't tell me the right thing, then I am in a soup. If the teacher does not provide the right environment, then both of us are in a soup. When I say both, me as a parent and my child, who is growing normally into an abnormal world. So yes, ma'am, thank you for that question. And thank you for underlining this need for having this conversation right from the beginning, that this topic is not something which can be covered in one lecture or in something which is done only in a Pride month. It needs to be taught as a subject, and it transcends right from pediatrics to geriatrics. It transcends from medical colleges to social institutes. It is something which we need to know. Yes, the world is not flat.
Yes, Dr. Sharma, it is very, very important. Just last comment there. See, we have to see what is our area of influence and what is our area of concern. This concept is very, very important. Definitely, social structure, society, school students are our area of concern. But area of influence is, yes, definitely medical students. Area of influence is members of Indian Academy of Pediatrics, members of Indian Medical Association, and nursing colleagues also. So we should begin with our areas of influence, and definitely we shall go ahead and try our influence on other sectors also, social sectors also. I think that should have answered all the issues raised by several people in the chat. And this whole objective of this whole series is to make people aware that these issues exist, and all the professionals, whether they are the current professional or future professional, we also need to learn about it and to practice it properly. And one word more, which Dr. Sharma said, I would like to underline that we need to understand that what is cure and what is care. And for this, care is required and not the cure, because these are normal people. I'm repeating this because to understand this and to accept it is also a big achievement. So thank you, Dr. Gill, for this nice conversation, and thank you everyone for giving us time. Over for the next program.
Thank you so much, Dr. Gale, and thank you so much, Dr. Pemde. That was truly a very insightful conversation, and our audience is actually very, very happy to hear all of those. There is a beautiful inflow of love in the chat box, and there is this one person, Prerna, who is a gender studies student from the AUDQC of a college. She is a non-med, and she would like to make a comment here. So, Prerna, can we hear from you?
Sure. Hello, everyone, to the eminent panelists and to the doctors who are available and present over here. It is such an honor to be speaking in front of all of you and to bring in a perspective from the social sciences in this panel. I, in fact, have talked to a few members, including Prachi of Queerentia. I come from the Ambedkar University, Delhi Queer Collective. I was part of the Queer Collective, and we had a conversation a few months back about how an interdisciplinary approach could be taken when we come to talk about something that comes under the purview of gender. And Dr. Neil Knudsen very nicely highlighted how interdisciplinary nature of an approach, an interdisciplinary approach is important. And I'm very happy to highlight that I, as a gender studies student, a master's in gender studies student, was able to gain a knowledge from an interdisciplinary lens. We did not just talk about gender as a societal construct, but how it is formed through notions of science, and how even in space, in time, gender is constructed. And when Dr. Pemde talks about research is having to be conducted, I would like to highlight the fact that a lot of us in the social sciences have actually been conducting and working on the ground, and the research is already there, sir. If we want to, the one thing that I've been talking to Pankhuri from Queerentia and Prachi also about has been that there needs to be a conversation between the two, fields, and that is exactly what I have come here. And when Comrade Sharma talks about the importance of the medical practitioners as well as teachers, I feel that researchers over here, social sciences researchers, also play a huge role in bringing about data and bringing about the problems, bringing in front of everybody. So I myself am actually working with Transform Schools, which is a civil society organization. I'm working there as a fellow, and I'm working on creating an inclusive, comprehensive sexuality education module, which is set for the cultural diversities in India, and not just caste, sex, gender, age, but also disabilities and ability. So I, as a student of gender studies, have tried to make an effort, and I would be happy to have a conversation with everybody over here. And thank you so much for giving me the space, Prachi, to talk about this. I just thought that this should be brought forward because things are already happening, but they're happening in isolation. And this has been because the nature in India has been, sciences are different and humanities is different. But I, being a product of interdisciplinary learning, can happily say that it is happening. There just needs to be a conversation. Thank you so much, everybody.
Thank you so much. It was
Prerna,
absolutely amazing to hear from you,
and I think
Prerna. And before we move on to our next, go on, yeah.
I'm so sorry. This thing, I just wanted to raise one point that I thought was in the chat as well. And it really ties to what Prachi were saying, Prerna was saying about this, that, and this is something that was raised by Dr. Kavita about how if we solely focus on the medical aspect of things, then we risk sort of like running the risk of pathologizing and medicalizing this issue that does have a very sort of interdisciplinary perspective to it. With that being said, it is exactly with webinars like this, when we have these perspectives, that we are able to push forward and sort of not make everything so pathologized. Anyway, right back to you, Prachi. Yes.
So that was amazing. And Dr. Kavita, it is amazing to hear from you again. You were a speaker in our last webinar, and we can't tell you how happy we are to see all the love pouring from you in the chat. So ma'am, thank you for everything. So before we move on to our next speakers, we have a very, very special video message from an extremely eminent personality, Dr. Bilal Kamra. He has more than 30 years of international and national experience in health policy, epidemiology, clinical sciences, medical virology, advocacy, and rights to health. He has been conferred with numerous prestigious awards. He was a member of the United Nations Millennial Development Goals Working Group representing the Caribbean region. And before his appointment in India, he was also the country director for Nigeria. So we have a very amazing message from him. So Athi, can we have that played?
Dignitaries on the dais, dignitaries of the dais, dear participants, facilitators, friends of the civil society. Thank you for this opportunity to share some point of reflection with you on how UNAIDS believes in inclusion to end inequalities and answer to the needs of transgender people in India. I will outline my contribution this way. As the Transgender Act is about health and complete well-being of people in this group, then we need to develop a well-resourced, comprehensive framework which will help all stakeholders to attend the transgender needs at every stage of life, from childhood to adolescence, adulthood, and old ages, as each of these stages of life will require specific attention to different issues facing the transgender. Therefore, a continuum of care, psychological and social support, medical attention with human and civil rights, social and legal protection are fundamentally necessary in every environment, from the family to community to schooling to employment and to workplace. My conclusion is that going full force is the answer under actual realities, and also that one single ministry or program cannot solve this huge social challenge. Therefore, let us establish a comprehensive framework which engages key stakeholders, such as the Ministry of Social Justice and Empowerment, NACO, Ministry of Health and Family Welfare, Ministry of Women and Child Development, Ministry of Education, Ministry of Home Affairs, Ministry of Defense, Ministry and Ministry of Labor, to be implemented in collaboration with the transgender community and the civil society. Working through state and district structures, stakeholders will deliver on their roles and responsibilities to ensure that the full benefit of the Transgender Act reaches transgender people from childhood, adolescence, adulthood, old ages, until death in dignity and decency. It is certain that despite all the challenges, every transgender child in Bihar or Manipur, every transgender adolescent in Bengal or Maharashtra, every transgender adult in Delhi or Nagaland, or every old transgender man or woman in Gujarat or Odisha should have the opportunity to enjoy the fulfillment of his her dreams, living in a safe, healthy, and supportive environment. Let us remember that human rights are non-negotiables. I thank you for your kind attention and wish you a successful webinar. Thank you.
I think the whole crux of human rights are non-negotiable is a really powerful thing to kind of like, move forward with. And just before we sort of get into the next set of speakers that we have for you guys, we have a conversation between Commodore Dr. Sanjay Sharma and Dr. Wallace Wong, who has written several books on childhood and adolescence and childcare. I think one thing that I would like to particularly highlight from the previous conversation that we've been having, and even the conversations that are happening alongside us on the chat, is that the importance of taking a public health approach to an issue as vast as transgender healthcare. And it's also the importance of, like everybody has been rightly pointing out, civil societies. And it's important to note that the inclusion of medical students as well as non-medical students in these research fields provides invaluable data with which we can kind of like have an on-ground idea of what's going on. And this data needs to be communicated to the medical fraternity as well. Now, obviously, this is a webinar that is being held particularly for people in pediatrics. And I'm going to let Dr. Sanjay Sharma and Dr. Wallace Wong take that forward. So guys, please, the floor is yours.
Thank you, Tia. And before I, start my conversation with Dr. Wallace Wong, let me tell you a little bit about Dr. Bilali Kamara. Dr. Bilali Kamara has been a pillar of support for us. And he has this beautiful way of, communicating with the government, with the private sector, with people in the public sector, and highlighting the importance of human rights. the bottom line is that we are all human beings and our rights need to be respected. So taking it from here, Dr. Wallace, in India, we were still, at a space where transgender health was something that was done in Bangkok. Not something that is a part of, what normally happens in our hospitals, because our hospitals are still battling with infections, and really in the public sector, transgender health is not a subject which anybody talks about. There are no role models. There are no postgraduate courses. There's in fact nobody that if I as a medical student would want to pursue in a government hospital, so to say, I would never see somebody practicing transgender health. We might have some people who would be faced with this issue, probably with neonatologists when they talk about ambiguous genitalia, and maybe later with pediatric endocrinologists when they would talk about precocious puberty. But then that's about it, And yes, pediatric surgeons may be operating some interesting cases, so to say. But transgender health, as such, is really something which is not known. So my first question to you, or rather, the lead to you would be to, just take us through this journey that about the gender development, and a little bit about how does one land up in gender dysphoria, and what is all this about?
Thank you for having me. I think definitely is like in terms of providing care for children, especially if they will present with some gender identity concern, I think it's very important to work with multidisciplinary team. So I think that relying on a medical doctor team to provide part of the care for the kid with gender dysphoria or gender identity concern is important. But also, like I think I noticed other people say, the school part is also important. The parent education is important. The psychological mental health department is also should be part of it, to work together to provide a collaborative care to help the gender diverse community. I think that would be the more ideal way to approach this. In terms of children, they come to us. I think we see as early as like 2 years old, they will, for some severe gender identity concern, will show up at our office. I happen to work also at the government office providing mental health. So as early as 2-3 years old, they will come to us. And have given in mind, so children, they tend to learn about the gender identity as early as 2 or 3 years old. And for those who have severe gender dysphoria, that may be the time that they may disclose some discomfort to their parents in terms of about see their gender identity and their sex not quite alike together. But however, because they're still children, we still try to provide care and support so that we can able to see how they develop. So the most important thing is always the persistent, insistent, and consistent. We just want to see how those gender identity concern able to persistent, consistent into the puberty. Along the way, how we can provide support to help them to affirm their gender identity, learn about themselves, explore their gender identity, and be able to consolidate the gender identity.
Thank you so much. So the catchword is persistent and consistent. And I think that's a very important message for the pediatricians, especially the ones who monitor development. Development pediatrics is something which is coming up in a very big way in our country too. So while on this thing, could you just elaborate if there are any other red flags that one should be looking at? And why I talk about red flags is because in our country, the pediatrician's office is quite busy. They end up seeing 40 plus cases on a daily basis. So could you just educate us about the red flags?
Mm-hmm. I think that in terms of red flags, I think when the kid displays with gender identity concern, I think the most important thing is have the parents and have the finding out how will be the best way to provide care and support their kid. Because if not being well supported, a lot of time, this is the time then that the kid will develop a sense of feeling inferior. Very fast, the kids will learn that the society expects certain gender behavior to be present, or gender conforming ways to be normal. So very important that early on, I think it's important to have the parents to be able to get the education and be able to get the provide support for the kids. That will be important, because down the road, if not, then the kid will tend to have lower self-esteem, may have some anxiety issues, may have depression, may have social anxiety, and so on, different mental health, which can be minimized or even prevent if we're able to provide adequate care and support for the kids early on. And of course, some of the kids, they may be comorbid with other issues. I think we can talk about it down the road. But I think the most important is able to identify the concern of the kid and be able to get the help that you need and the education that you need, so that we can provide evidence-based care, and then be able to have best support for the kid. And that would be the ideal.
So what I'm hearing is that this is something which requires probably a team effort to come in, and the pediatrician to be aware and look at the child, listen to the child, and look what the child is doing in their pretend play, look what the preferences are, respect them, and probably take the parents to also understand that these are issues which are perfectly normal, and we would be requiring a team approach to handle them properly. So when we talk about the pediatricians, when do you see the pediatrician to start shouting out for other specialists to come in? When would you want the primary care provider to activate the whole team as such?
Mm-hmm. I think a lot of times that when the parents seek out precision and seek out care and support from them, a lot of the time that the doctor will referring the clients to us right away, and so that we can able to work collaborative together. A lot of times that we will do the assessment and just to find out how to best support the kid and any other comorbid issues going on. And then we were able to provide assessment report to the doctor, and the doctor will have some ideas from the psychological mental health point of view, how can they also help support the kid, so that we can work together to provide information for the parents and the child, how to help them to address the gender identity concern and foster healthy development, so that the kid be able to learn about who they are and have a consolidated gender identity. And that will be ideal to work collaborative together. Of course, the prevention care is always the best care. Work together as a team with other disciplines will be, I believe, is the best way to provide care and support for the family as well as for the kids.
There's another dialogue that we are hearing, and there's so much of talk about linkages of autism with gender issues. So this is something which we are, I'm sure all pediatricians are so curious about, and who best to answer than you. Could you throw some light on this?
Yes, and that which is very true. We do find more gender dysphoria, kids with gender dysphoria, they tend to have some signs of autism, and they tend to have maybe higher percentages than other kids who doesn't have it. Having said that, I think it's important to highlight that just the kid happen to be autistic, it doesn't mean the kid, they don't know about their gender identity. They still do. But the way is they deal with it, the way they express it and communicate with us will be slightly different than kids who are not on the spectrum. So I think that's very important for parents to know, because a lot of time they think, because my kid is on the spectrum, autism spectrum, my kid may not know about their gender identity, and which is not true because they still have a sense who they are and what they are inside. The only way is for them to figure out and to express that and communicate with it and deal with it is sometimes is more challenges than kids who are not on the spectrum. For example, the social interaction. A lot of times that they may have reading social cues and social rules a little bit more challenging for them. So learning how to be a gender minority and be able to communicate with other people and interact with peers who are maybe not understand what my gender identity is can be challenging for kids who already have that deficit to start on. And some of them, maybe they also have some sensory issues. So having that sensory issues, so having them to attend the group to learn about who they are sometimes may not be ideal because they're so easily overwhelmed by noise, by big crowd. So we have to find a way to help them to consolidate the gender identity, learn about themselves in a more unique and personalized care plan for them, rather than the cookie cutter. This is you because your gender dysphoria, therefore you do A and B and C. That may be good for some, but may not be the best approach for kids who happen to be on the spectrum, who also happens to be transgender.
Thank you for that insight. And so what essentially one has to be aware of what is happening in other fields and how it does relate to children. And children, when we look at any child who walks into our clinic, I think as we measure the height, the weight, and the vitals, we should also be doing a little bit of monitoring as to where does this child stand on the psychosexual social development stage.
Mm-hmm.
And probably this is something which should come into our teaching and clinical practice. Your comments on that?
Okay, I think that the question is, I don't quite get the question. One more time, sorry.
Yeah, so actually to put it simply is that, is there a need for each and every pediatrician to also monitor gender and give it the same kind of importance as it would give to weight of the child?
Mm-hmm. Yes, I think that is very, not just for physician, I think it's for all the medical doctor who is learn about gender and gender identity and other sexuality of children and youth. I think sometimes the parent will take the kid to see pediatrician, but sometimes the kids may be on crisis, they will take the kids to emergency room. Right. So I think the doctor should be starting on have that kind of knowledge to anybody can come to your door with gender identity concern, with sexuality concern. And especially if doctor being able to identify some of the early signs and be comfortable asking those questions, that would be important. And especially children, we don't think about children also have feelings about sexuality and gender identity. And I think that able to have being sensitive and read some of the signs and be able to ask the question, feel comfortable to explain those to the parents will be crucial, because sometimes the sign can be quite subtle, and then be able to read those signs and be able to understand what's going on and be able to provide education and preventive care for the parents and for the youth that can go a long way and prevent a lot of unnecessary mental health and any crisis from happening down the road.
Thank you so much, Dr. Wallace. But, you are not going to be let off so easily. There are some questions that are there for you. So quickly, just give a small message for the medical students. And then Tia and Prachi are just waiting to ask questions to you.
I think for the medical student, I think definitely is you will be the future for this, providing this kind of care. Having this knowledge, understanding will go a long way, and then able to work collaboratively with other disciplinary, and then be able to work together to support the kid. It is very rewarding and is such a powerful thing to be able to see how the kids can grow up to be just as happy, as productive, as independent as any other children do if we able to provide the support, the care for the family, the parents, and the kid. And the development can be just, the outcome can be just as positive as any other kids.
Thank you so much, sir. That was very insightful, and all of your inputs and your valuable points in your conversation were very, very nicely appreciated by all of the people in our chat. We have Dr. Priya Shankar in the chat and in the audience with us. We had a session on sexual history taking with Dr. Priya Shankar. She is doing a fellowship from Lady Hardinge Medical College. And she is actually very, very happy to be here, and I mean, all her love is being seen in the chat. And regarding that, Dr. Priya, if you'd like, we would love to have a comment from you if you're okay with it. But right before that, Dr. Wallace, we have just one last question for you, if that's okay.
Yes, definitely.
So how do we create a safe space for a child so that the questions regarding gender and sexuality can be asked and answered in a very holistic manner, considering that children are still at an age where they don't understand the basics of all of these?
Okay, I think that the safe space, I think the safe space should be everywhere within the child development, including school, including the community, including family at home, including the medical settings. I think that should be a safe place where the child have those discussions going on. But and on top of that, a lot of times the parent ask me, when is a good time for me to talk to the kids about this? Would they be too young to know about this? And my experience is never too early to talk to the kids about gender identity and sexuality, as long as we use the language that fit their development and the content that fit their development. And if that is the case, I think we can communicate different sexuality information with the kids and gender identity, because when the kid learn more about this, they will learn to use the accurate language to describe how they feel. They were able to have a safe place to talk to their parents about it with the proper language and vocabularies. And they also learn how to advocate for themselves, because now they have the knowledge, they have the vocabulary. So they may not feel, sometimes they may not feel safe to talk to certain individual, but they will say, you know what, there's school, I can talk to the school counselor, or maybe my family doctor who happen to be more open mind, I can talk to them, and using the vocabulary that they have learned. And that will go a long way for them to be able to self-advocate for themselves too.
Thank you so much. Actually, before we let you go and before we move on to Dr. Jennifer, there was a very interesting comment made in the chat that I would also like to sort of like talk about is the question about children with indeterminate gender. Now, I think what here we're talking about is children who are born intersex, and the notion that if somebody is born with indeterminate gender, this thing they should be referred to an endocrinologist for proper assessment. It is a dated notion. Surgical intervention for intersex babies is quite it's a dated practice. But what would you have to say about sort of like intersex people and how the medical community sort of addresses that as a form of gender variance or gender equality?
Mm-hmm. So, I mean, in my years of practice, we have a few intersex individuals. And I think it's very important. Early on, I think that in the earlier days, the medical practice is easier to make the intersex baby into a firm female. And raise it that way. But what we learn in the experience is important to give the kids the chance to explore, consolidate, and so that they can know about their gender identity. Because it will predetermine about what their sex and gender should be early on, that can actually interfere their later gender gender identity development, because that they will come to sense who they are, what they are, when they mature and learn about themselves. So when they learn about themselves, who they are, when it's not being aligned with their gender sex, that will be where the gender dysphoria comes in. So my advice is like, allow the kids to have that time and to learn and consolidate their gender identity will be ideal, rather than we are predetermined where that should be. because that actually can be detrimental to the kids' development.
Thank you so much, Dr. Wallace. Now we'll be moving on to Dr. Jennifer Slovis.
Just one second. Sorry.
Yeah.
We have Dr. Priya who would like to speak for 2 minutes, and she is very, very excited. And ma'am, we would love to hear from you here right after we move to our next speaker.
Fantastic.
Mute. Oh, hi everybody. I definitely don't want to disrupt the conversation happening here, but I'm just wanted to say congratulations, and I'm so impressed and really blown away by this group here. You know, it's just that I really want to acknowledge the initiative of the students and Ati and the many collaborators here. And it's for me really amazing because I am sort of a third culture kid. I'm from the US, and I'm a pediatrician, and I'm an adolescent fellow with Dr. Pemde, also running an NGO for students and youth. And so I'm actually from UCSF. I've trained at UCSF, and so I have that part of me in me. I also have the Indian American in me who's so passionate about thinking about coloniality and how does that influence gender? How does that influence our ideas and notions of gender? How has colonialism impacted that? And how do I think about it from the space of the medical hospital, the hospital setting, from the school setting, from parents who can be supportive, but who also can be, really can hinder the support that youth really need. And, you know, also teachers. And so that multi-pronged, multi-sector approach, I think pediatricians, I feel, can step out of our comfort zone a bit sometimes, and we can lead the conversation in multiple sectors, and we can actually hold hands. We can actually hold hands with professionals from many, many different platforms, whether it's psychiatry, psychology in the schools, the teachers, the medical students, you know, and really embrace that. And I really appreciated the comment by Prachi about that interdisciplinary nature. I just wanted to mention that, and also say I'm really, really grateful to see this and to see this conversation happening. I hope to be part of it and to contribute to it and to support in any way I can. And yeah, I just wanted to introduce myself and hope to collaborate in the future. And congratulations to this group. I think this is huge. This is huge. This is huge. This is like, what a wonderful day on Independence Day to be having conversations about this, about gender, about the history of colonization too, about how did that impact our notions of gender, and where are we going to go from here? How are we going to take the conversation forth? How are we going to make our own notions about such a, like, how do we stop this gender binary notion, such a restrictive notion? How do we move forth from that? So yes, it's a beautiful day for this conversation, and I hope all of you are just as inspired as I am. So go ahead, everybody. Sorry to disrupt this conversation, but yes, I'm really touched and grateful to all of the doctors, including Dr. Pemde, who's been really, really passionate about this and pushing this forth.
Thank you so much, ma'am. Thank you so much. It is always lovely to hear from you. So Tia, go right ahead.
Ma'am, I don't think you interrupted anything. I think this was a very welcome injection of just enthusiasm here. And you know, this is the kind of audience interaction that we really like seeing. And it really does help us feel like we're reaching out to people and we're connecting. Now, I mean, we're going to move on to Dr. Jennifer, and Dr. Jennifer has a fantastic presentation prepared for all of us, specifically talking about childhood and adolescence, right? And I think it speaks for itself. So Dr. Jennifer, please take it away.
Thank you all so much. What an honor it is to be joining everyone and my fellow UCSF, University of California, San Francisco. What a beautiful interjection. Thank you. So I am going to share a PowerPoint. I work with young adults mostly, but I also I partner with our children's and pediatric clinic at the multidisciplinary clinic that I work with in Northern California at Kaiser Permanente. And so I will also be talking a bit about the patients that I pick up from my pediatric endocrine colleagues when they are old enough. So I'll be mostly talking about adolescent and young adult care today. Okay, and let me just pull up my PowerPoint. Okay. Okay, and this is a bit of my credentials and experience. And I always like to start my talks with showing some of the beautiful patients that I have the honor of participating in their care. And these are gender diverse patients who have agreed to share with colleagues. You know, and I do have to say, Prachi, you mentioned that teaching is not something that medical students and residents often get. And here in the United States, it's not something that's routinely part and consistent in curriculums as well. So I do believe that making sure to have comprehensive care and training really does begin with your generation. And thank you, because also my generation did not have the benefit of training. And so you will be teaching your attendings and your senior providers about what they need to learn to provide comprehensive care, as well as consistent care for everyone we're working with, whether gender diverse or not. And as I hope everyone is learning from the conversation today, you know, you will be working with patients who are young, maybe exploring their gender identity. So there isn't always going to be very black and white, obvious things. So if we standardize these questions and histories and exams for all of our patients, we'll be sure that we'll be inclusive, no matter how anyone identifies. So today, you know, you are not going to become an expert, right? And you don't need to be one. I like to focus on the kinds of skills and things that primary care providers need to be thinking about, or when you're working in interdisciplinary teams, right? Because the majority of patients coming to you will be seeing you not in gender clinics, but in your routine practices, right? And so, and patients need more than gender care, as of course we'll talk about today. And yes, we will be focusing on adolescents and young adults. And also the main takeaway today, your patient's decision to disclose these very intimate personal parts of their lives to you comes with great privilege, but also great responsibility. You might be the only person that your patient has shared this information with. And so it is upon you to be sure that you are providing accurate information. And what you'll hear a lot about the terms safe space, to make sure that patients feel that if they are sharing these things, that your care and support of them will be affirming and positive. Okay, so we're going to start a little bit with definitions. This is our genderbread person. And really, this is just to help us understand that gender identity is something, something you know who you are, right? Have you ever had to question yourself, am I a boy? Am I a girl? Many of you had not. And so this thought of, well, of course I know who I am. Who best to know who I am than me, right? And so this is something you know who you are. Now, often people get this confused with sexual orientation, which is who you have romantic feelings for or who you love. They are not the same. They are very independent. Someone can have any gender identity, and that gender identity can be transgender, which just means, you know, opposite of, for most people, what your birth certificate says that you were assigned at birth, or cisgender, which it's the same. There can be a very wide spectrum where people can, you'll start hearing terms like gender fluid, gender non-conforming, non-binary, gender queer. This beautiful generation has come up with all sorts of definitions and language, and it continues to expand. And then there's sexual orientation, heterosexual, homosexual, pansexual, asexual, also a very wide spectrum. And again, anyone can be any gender identity and have any sexual orientation. They are not the same or exclusive. Now, sex tends to be what someone is assigned at birth. And we've heard our previous speaker speaking a little bit about intersex. Again, a very separate category, and it is not, doesn't really have anything to do with gender identity. And then there's expression, which is a completely different thing. And expression is how other people see you, how you choose to dress or express your gender identity. Some people will feel they are in a safe space and have support, and they are able to express their gender identity, how they want the world to see them. Others will not, right? So someone doesn't have to act or dress or look a certain way to have a gender identity. And that's very important to understand, because if someone is not in a position, their family or parents are not supportive, their community is not supportive, or they are just beginning to explore their gender identity and they don't feel confident really dressing or expressing a certain way, does not determine what someone's gender identity is. And that's important to keep in mind. And as I mentioned, like if you look at Facebook, there's over 50 ways that people can now express their gender identity. That list is continuing to grow and grow. Now, often people will say, well, what are the percentages, right? Now, I will be giving you a lot of statistics today, which really are from the United States. And so I do keep that in mind, that for the Indian and subcontinent population, it is going to be very different. But certainly, when we look at studies, we feel that if we are asking people, right, are we asking people their gender identity? And then if people feel comfortable saying, yes, this is what I feel my gender identity is, you're looking somewhere between about 0.6% of a population, maybe even up to 1.6% if you are including people who identify as non-binary as well. Now, well, what is in India? What are your percentages? Now, this is a census that was done in 2011, right? And this is adults, right? Because the census was asked through people's employers, literacy, their caste system. So we have to keep in mind, again, how are these questions asked, and do people feel that these questions included all the diversity of the ways that people describe their identity? And did they feel safe disclosing this information? But this talk really is about adolescents and children, right? So I will tell you, we don't know exact numbers because number one, are we asking the information consistently? And we're not. And then number two, we are talking about a population that might not have the language yet, or this is a development thing, right? So children may not know exactly where they are, especially if they are beginning to question or explore. And we do know that as a child starts presenting some of these red flags that you heard about, really, as they're getting closer to adolescence, where we start feeling that gender may be a bit more fixed, that meaning that if someone is exhibiting a lot of distress, by the time they are in adolescence, they're starting to experience puberty, that the more distressed our adolescents are, perhaps the more persistent they will be in their gender identity into adulthood. Okay, so when we're working with transgender or gender diverse youth, there are many things that we need to keep in mind. And unfortunately, our youth have some of the highest disparity rates, which is really unfortunate. So we see higher rates of depression, anxiety, attempts at self-harm or suicidality. We see higher rates of attention deficit disorders or eating disorders. And as you heard some of our previous speakers mention, there are higher rates on the autism spectrum. I believe there was a study that came out of the United Kingdom that said possibly 3 to 6 times higher. Higher rates of homelessness. And we know that all these disparities, and I've included a poster that you can see on the side from a study where you see these very high differences. And these differences really are a matter of society, right? The main thing that makes a difference between someone having positive experiences or negative experiences is the support that they have around them. For many of the youth, it will be their families, but for some people, it becomes more of chosen families and community support. And as you can see, some of the very upsetting things, the homelessness, attempts at suicide and mental health status, all of these really revolve around, is this person with a supportive family environment or not? And that really is the critical thing that can change things. So this is why when we work with children and adolescents, I often say the kids know who they are. Really, a lot of the care is about making sure that the families and the supports are hooked up with the right people to help them understand their child and support their child. And that's really where the difference is going to become. It's really about buying them time for the family to get on board. And sometimes I will say to my adolescents, I know you are fine, but let's make sure that your parents, that we can bring them along on this journey, because you have had lots of time to understand and learn about who you are, but this is very new to your parents and your family since you have disclosed to them. So they need a bit of time to get educated themselves. We know that gender affirming care is critical, life changing, and I hope throughout this series, this will be a major takeaway for all of you. And we also know that our youth, especially with more representation in the media and society, our youth are presenting and becoming visible earlier, right? And so this is why you're starting to see more visibility as society creates a space for people to feel safe and affirmed. People will become more visible. It's not that there are more, this isn't a phenomenon. This is just something people are feeling more safe disclosing themselves, right? Because we know that gender nonconforming people have been around since the beginning of time. It's just more of, has society allowed a safe space for people to be visible? And of course, especially when we're talking about youth and families, we must make sure that this model of care is all inclusive and interdisciplinary. Here's another example of a report. This is out of Canada, again, showing when you have support, when you don't have support, the wide array of disparities. And of course, some of the highest disparities: homelessness, attempts at suicidality, not having enough food or safe resources, really, again, evolves around people being supported. And we have good research showing that when people do have support they need, whether it's medical or any other factor, that these youth do very, very well. And this is nothing new, I should say. The Dutch have over 30 years of research following gender diverse children and their families. And so we know how these outcomes go with support, and for the children who need it, access to medical care, which we'll be talking about next. Okay, and this is out of your beautiful new 2001 Indian Standards of Care. Now, I will say a lot of what I'm talking about today, of course, I work in the United States, so I have a little bit of a skewed perspective, but I also want to say that your Indian Standards of Care have very clear guidelines about the medications, when you check labs, when you intervene. And so I will defer, of course, to the Indian Standards of Care for any medical care decisions that may be different from what I'm used to doing. But I will say that this model of what an interdisciplinary team and clinic should look like is very similar to the clinic that I work with in the United States. Because prior to puberty, my services are not really needed from a medical perspective, but from a prescribing perspective, because really the care is about the child and their family and the supports and what life looks like in school and for the family and the psychological and social resources that the family needs. Okay, so let's talk a little bit about primary care. And guess what? It's not that different from any child or adolescent that we might be taking care of. So when I'm thinking about especially young adults, I'm starting to think about sexual activity and what those risks might be, right? And we'll talk a little bit about how do we ask those questions. Now, some of this is, an adolescent is starting to explore their sexual identity, their orientation, their gender identity. Some of this will be for survival, right? As we know that many of these children, unfortunately, especially if they're in situations of homelessness, that they might be engaging in sex for money, for housing, for food. And so we do need to keep that in mind. Of course, other things that we know put our youth at risk: smoking, drugs, alcohol, pregnancy risks. You know, the question isn't what is our patient's gender identity or sexual orientation, but often are they engaging in sexual practices that for that person and that person's anatomy, right? Which could be different from what we might think about for someone's for someone's gender identity. Is the anatomy that a person has and the way that they engage in sex, does that make them a pregnancy risk? And if so, then we need to be having our conversations with our patients so that people are not getting pregnant if that is not their intention. We already talked about higher rates of depression, anxiety, suicidality, healthy weight and body images. Sometimes patients will gain weight or lose weight, again, to try to support their gender identity. And we want to make sure that this is not done in unhealthy ways. Of course, vaccinations, HPV vaccines for our youth to make sure they are protected from certain cancers. PAP screening, which in many countries now is becoming primary HPV screening, which is really wonderful. I look forward to the day where we have the option of self-swab HPV screening universally. I think that will really help for many of our patients who avoid coming in for those invasive PAP smears or exams, cervical exams, that they avoid the care. Of course, bullying, harassment, violence at home, school, other places, safe and healthy relationships, right? We see intimate partner violence with any population, and our gender diverse population is no different. It's just that there aren't resources available to help people. And of course, when we're thinking about our youth, we always need to be thinking about role models and mentors. And our gender diverse youth may not have that, right? Coaches, teachers, religious leaders, who sometimes often youth will look toward, if not their own parents, for support and validation and affirmation. And our gender diverse youth may not have this. So what's unique about treating our gender diverse adolescents and young adults? Well, of course, the parents and the family are involved, right? In fact, I may not even be working with these patients if they don't already have a supportive or at least open family involved, because their family takes them to the clinic, right? To the provider. So it's very important to make sure that our parents and family members are what we say on board. Of course, decision-making capacity, right? There are ages of informed consent. And so if the parents are not on board, then care is going to be much more difficult. Legal, bioethical concerns and developmental stages and maturity, of course, always come into play. And what is the environment, right? The school and the home environment looking like? Affirming, supportive, or not? And of course, now we'll talk a little bit about the effects of puberty blockers, which really medically is the only intervention prior to puberty. And then, of course, hormone initiation when it's appropriate. Now, I will start off, we're going to talk a little bit about language, because this is something that everyone needs to be doing and supporting, right? And it's not just medical environment, it's everyone. We open safe spaces with demonstrating and modeling to patients that this is a safe space and I will support you. So I am starting with Nina, and it's interesting because I saw in the chat, I believe her story, or at least an organization that she's worked with, was mentioned. And in 2015, Nina came out at a school assembly in Delhi that she shared her gender identity, and she's considered to be one of the youngest openly transgender people in India. She's become quite a social media star and really has, as I believe we saw in the chat, someone said, you know, the youth are really starting to open up these conversations, and how wonderful. Now, she also has experienced depression, suicidal tendencies, and she did an interview with Breaking Barriers where she mentioned this. that, you know, this was not an easy road for her. But then she said this beautiful statement, which I want to quote. She said, while there will be those 10 odd people who will ask me these random questions and tell me that being transgender is unnatural, I just go and talk to my friends who really love me. I have a lot of support. They do not treat me differently. They treat me the same. They just treat me just like any other girl, which is what I love. And so again, the theme today, with support, people can thrive. And yes, our youth and adolescents, that will have all the same problems and issues as any other adolescent that we work with. But if we can create this safe space and support, there's no reason that our transgender and gender diverse youth should do any differently. So how do we open up the conversation? Well, the first thing is, how would you like to be referred to when I'm working with you? So many of you saw my name is Jennifer. I go by Jenna as my preferred name, and she, her is my pronouns, and really just normalizing this conversation, asking this of everyone we work with. What name would you like me to address you by? Or what would you like me to call you? And making sure that we document it with our patient's permission as we go along, to make sure that anyone else who's working with our patients, who's in the charts, who's reading our notes, can also be supportive. We call that when someone does not address someone by someone's name or pronouns, we call that misgendering. And so we want to make sure that we can decrease that misgendering experience, not just myself as the provider, but by the receptionist, by the social worker, by anyone who's working with my patient. And confidentiality is something we really need to be thinking about, right? Because our patients tend to be coming with us with our parents. And so I think many of you who work with children already probably have a tradition where you will say, okay, at this point, I'm going to ask the parents to step out of the room to really create a safe, confidential space for your patient. And certainly, should any parts of the exam be more private, not just genital exams, but if you're doing upper body exams, for example, listening to someone's heart or lungs, patients may be wearing binders. And again, this is a very sensitive area, so we need to be keeping that in mind. Talking about treatments. Now, when we're working with youth, you know, we're not going to be talking about surgery really a lot. Now, certainly with some of my young adults who are of the age of consent, many have had surgeries. And so certainly knowing the body parts that they have is going to be very important when I'm determining what preventive care exams that they need. We talked a little bit about a safe space, but this also isn't just people asking affirming questions, but creating spaces that are affirming, making sure that people have access to a restroom of the gender identity that they would like to use, right? And of course, a gender neutral restroom, single stall restroom is always going to be easiest for everyone. But when you're not in a position where someone has that, making sure that people can use the restroom of how they identify is very, very important. And making sure that forms are gender neutral as well. And they don't say things like she and her, unless patients are given options of choosing the, you know, checking the boxes that they feel apply to them, and then people respecting those choices. We don't make assumptions, right? This is one population we can never make an assumption. And also with fluidity, their identities, the names they'd like to be called might also change a bit over time. And I'll give examples of saying that also we're starting to see higher numbers of people saying, well, I don't identify as male or female, but more non-binary. And the pronouns I like to use are they and them. And that's okay. And so sometimes this might change over time as well. And it doesn't mean that our patients don't know who they are. Some of this is just more comfort. As people get more comfortable in how society sees them, they will start to share with us more about how they feel. Okay, and we will always make mistakes. And it's okay, you recognize it, you honor your patient, and you move on, and you try not to make those mistakes again. So building trust, normalizing the conversation, and I'm going to also introduce you to Shivi. Now, Shivi was in the United States for 15 years studying in University of California, neurobiology. Shivi went home to India for a for a visit. And while in India, unfortunately, Shivi did not have supportive parents and actually took away his passport and green card. And so Shivi is actually reached out to the community, and activists in the community and a support group have arranged legal counsel and have found a shelter for Shivi to stay in, since the family is not supportive. And in fact, in Shivi's thoughts, the family is trying to forcibly marry him off to a male to fix him, which we know is in this work, we know that actually is not something that will be helpful and will actually cause more harm for Shivi. So Shivi has asked the Delhi High Court to help him get his passport and his green card back, so he can go back to the United States to continue pursuing his degree in neurobiology. And so I don't have an update of what's going on with Shivi, but hopefully that will work. And again, as more laws, this also shows why laws are so important, right, to help support people who may not have choices. So here's where we start beginning the conversation and the interviews about asking, right? And I will say to patients, I'm going to ask you some questions about sexual health and sexual practices, again, making sure that our patients are the right age to be having these conversations. And I'll say I ask these of everyone. They are personal. So I want you to also understand that this is confidential, right? I'm not going to be sharing things with your parents or family that you don't want me to, of course. So sometimes saying, what genders are you attracted to, or how do you feel about your attractions? What words do you use to describe who you are? Now, in younger children, you might say something like, do you see yourself as a boy or a girl, or do you use other words? With older people, sometimes we can start saying, what is your gender identity, and giving people lots of choices, or just, having a blank space where people can say, well, this is my gender identity, none of those others fit. And when talking about gender, when I say gender, I mean, how do you think of yourself, regardless of the body parts that you may have, or what other people tell you that you are, is a way. Now, certainly with our young adults and sexually active adolescents, we might have to do what we call a deeper dive when talking. So when you're talking about sexual behaviors, it's really all about what you do and with whom, right? Not what is your gender identity or what is your sexual orientation. So talking about especially sex in the last year, and what does your patient define as sex? Who are their partners? What are the body parts or the gender identity of their partners? Have they ever been hurt by someone that they love, right? For patients who have a penis, sometimes we have to ask a little bit more about sex with sperm. And of course, much of this also is about condom use, barrier protections, or pregnancy risk, and also other sexually transmitted infections. If people have access to PrEP, pre-exposure prophylaxis for HIV, this also is where we start thinking about what might these be appropriate things to talk about with our patients. Talking about body parts, and really you take your lead from your patient, right? And so I might say something like, well, the medical word for this is vagina, but plenty of my patients have other words that they'll use to talk about their genitals or front hole. What language do you use? And of course, then again, taking the lead from your patient and making sure to use that language. Reproductive health and desires, especially for young adults. Some of our hormone interventions may affect someone's ability to have future fertility. And so especially with younger people, having conversations about, is there reproductive interest? Do people have access to store sperm or eggs prior to starting hormones, or to come off of hormones to do this as well, is very important now. And I think if people have access to this, and I will say to my patients sometimes, when you are 18 or 19 or even early 20s, I don't expect you to know what you're going to want to do as far as families and interest in having children of your own later on. But certainly I want to make sure that you understand your options now, so that when you are 35 or 40, you're not saying, oh, I regret that I could have done this, if people have access to this. And of course, this is things like sperm banking, or in younger children, there's also some other ways of harvesting testicular tissue or ovarian tissue as well. Okay, so we're going to talk a little bit about when do you start hormones and interventions. And for most children, we're talking about blockers, right? Because puberty tends to be a big source of distress. And that's also when many of our young people start to show and demonstrate their gender identity. Body parts are growing and changing that are not consistent with how your patient sees themselves or knows who they are. And so this can be very distressing. Also, when we can block people at puberty, and this care really, this is nothing new as well, right? Because we've also been doing this with children demonstrating precocious puberty. It's the same interventions, GnRH blockers or agonists, whether those are implants or shots, to stall puberty. Number one, it also buys you time, right? It buys you time for the child to become more comfortable in their gender identity, as well as buys you time for the parents to come on board as well, to be supportive. So blocking usually will begin at what we call Tanner stage 2. This is and I'm using terms of AM, AB, assigned male at birth, assigned female at birth. This is also when breast buds will begin to start, or when testicular enlargement, and I believe the cutoff is about 4 ml for your pediatric endocrinologists in the group. So if we can block, this prevents many of those late stage secondary characteristics. When I start working with people as adults, I can't reverse puberty. So much of the care that I'm trying to do with hormones and possibly surgical intervention can be prevented if the child or the adolescent is identifying early enough, and we can block that, what we call that secondary puberty. So for assigned male at birth people, or your trans females or trans feminine people, you'll start seeing that we can prevent things like facial and body hair, which we often say can be irreversible. The bony changes, the what we'll call how the face changes to look more like a caveman or Superman, you know, what we say are typical male features. The Adam's apple, the height or the broad shoulders, a deepening voice, and of course, enlarging genitals are all things that can just be put on hold. And for our assigned female at birth people, prevention of those bony changes. So hip development, what we call that childbearing hip enlargement, menses. Menses can be extremely distressing, and the prevention of breast growth are some of those things. Now, we're just stalling puberty here, which means that if any point the child or the adolescent determines that they want to go through the natal puberty again for the organs that they have in their body, whether testes or ovaries, that medication can be stopped and they can continue that puberty. For our gender diverse patients, puberty will be stalled until the appropriate age, and that may vary again around informed consent, an age that your country allows cross-sex hormones to be started. And this will vary in different countries. Certainly the thought is, especially if a person is blocked early on in puberty, that you will want to start cross-sex hormones at the age that their peers would typically be going through puberty, because you really want to make their experience very similar to their peers. Again, socially, it will help the child do better. And we know that, again, children who are supported with medical interventions, do better mental health outcomes socially, and so it's really there. Well, so certainly blockers can also prevent future surgeries, again, for irreversible changes that someone may get, like breast growth, for example, and they can integrate more easily in society. We use the word passing, which isn't always the best word, but certainly, again, if society is more accepting of someone, we do expect that someone will have a better experience. And of course, like I said, blockers can be reversible. However, right? When we are blocking, there may be a longer lag than a typical puberty, right? So if someone is put on blockers at around 10 or stage 2, let's say they're about 10, 11 years old, they may not be able to start their cross-sex hormones in some places like until 18 years old. That's many, many years where their bones, right, are not getting the benefit of those sex steroids. And so I think, again, with more research and more support, we're finding that we really want to make sure that patients who are persisting in their gender identity, if they are on blockers, can start cross-sex hormones earlier on when appropriate. Now, we don't know long-term risks, bone health risk, brain maturation risk, but certainly, again, this is a very similar process that we do with people with precocious puberty. So again, this has been done for many, many years, and we have many countries like the Dutch models that show us that these kids really, really do great. It's just we're always lacking research. And of course, we are lacking research in countries other than Europe and the United States and Canada, where many of these studies come out, right? Because your population in India is going to be different. So making sure you have setups for research as you are moving along in developing your programs is going to be so important and necessary to really make sure that you're addressing the needs of your population. Okay, so I'm showing you some of the hormones that are in your Indian standards of care. Much of this will be what do your clinics have access to. And I will also say that with children, there is a stepwise approach when you're introducing hormones. Okay, and so those are all in your Indian standards of care. I won't go over everything, but what labs do you do? When do you titrate things? What levels are you looking for? Are all going to be in there for your pediatric endocrinologists. And I'm also showing that when we're talking about feminizing hormones, we're looking not only at estrogen replacement, but what blockers are you using? What testosterone blockers? And some of those are going to be the GnRH agonists that we use to block puberty, but also if someone has gone through puberty or no longer has access to your typical children's blockers, we're looking at other things to lower testosterone levels. And there's a wide variety of medications that are used depending, again, what you have access to. And I'm just showing a picture of some of our Hydra daughters. And actually, for the Hydra community, many people, this is a community, not of blood, but a valid community where these young women are embraced and mentored, and this is where many people are learning about for social or for support that they may not have gotten from their own families or home. Okay, these are some of the changes you can expect when you're on feminizing hormones. And we'll often say that some of these changes with medications take about 2 to 3 months to start working, and you'll start seeing a maximum effect usually about 2 to 3 years. And of course, if someone stops hormones and they have their natal organs or testicles, we do expect that their typical natal puberty will continue. It is always important, again, to be talking about, especially before starting hormones, about fertility, interest and options for storage, as well as something like breast growth may not be reversible. And what's interesting is with some of our more non-binary youth and people starting to present, sometimes there's a sense of, well, I want these changes, but I don't want these changes. And unfortunately, just like with regular puberty, you can't pick and choose which changes you're going to have. So if a patient says to me, I am not okay if I have breast growth, that's not something that's in my goals, that's not something that I want. This is a very difficult conversation because I cannot guarantee that they're not going to have breast growth. And again, that breast growth may be irreversible. So making sure that our patients know that this isn't just something, well, I'll start hormones, and if I don't like it or if I don't feel good about it, I will just stop and any of these changes go away, is not realistic. So that is something that's important for the hormone provider to be having conversations with. And that's also why we check in as we're going along with hormones to make sure that the dosing is still consistent with people's goals. For masculinizing hormones, I'm going to introduce Aran. I will be talking about Aran a little bit more later, but he's known as India's first trans man bodybuilder on social media, but also He's very active on social platforms in the media. He's a Delhi-based lawyer, and he's very involved with organizations and working on the legal empowerment of the LGBTQ plus community, and especially working on a petition for gender-neutral laws. As we're moving forward. And we're going to be learning a little bit more about him later and some of the amazing work he's doing. But for masculinizing therapy, testosterone is very strong. So we often don't need to use estrogen blockers because at high enough doses or typical cis male doses, testosterone will be enough to lower someone's natal estrogen levels. There are many methods of testosterone. There's injections, there's intramuscular, subcutaneous weekly, at least in the United States, tends to be the most popular injection method nowadays. There's also an injection that someone can get every 3 months. That's also very popular. Daily transdermal things through patches or gels are also there. There's also buccal formulations and pellets. I don't work much with those. They're not available where I am, but certainly they are also options. There's also the option of just being on estrogen blockers in a way. So progestins might be used, or even GnRH agonists. For some younger people, maybe they're not interested in starting testosterone just yet, but blocking menses or periods is extremely important. And so for some of my patients, they're just on something to block periods. They're not necessarily on testosterone. They might not be in the future, or they might be, but at least stopping periods is something that's extremely important. And here you can see some of the masculinizing hormones that we use and the effects there. And again, a few months to start working or kicking in, as I say, and then 2 to 3 years for maximum effect. Now, there are some changes with masculinization. There are more irreversible changes. So things like facial and body hair, deepening of the voice, genital growth, which is usually going to be like enlargement of the clitoris, and of course, fertility. Now, those eggs are always in your ovaries, but certainly with menses stopping, and then as patients are getting older, we know that as people get older, fertility, may not be as robust. And so again, having options for people who want to do egg harvesting and storage, and as well as our patients, especially again, our non-binary patients, understanding that, you can start testosterone, but you may get facial hair, and that may not be reversible if that's not something that's in your goals. So again, we always have these conversations before starting hormones. I also want to bring up some of the non-medical interventions that patients will use, especially younger people. Surgery may not be in their goals, or they might be too young to be age of consent to have surgery, or someone may not have access to surgery because of not having access to the medical system to support their surgical desires. So in our transmasculine people, patients often will wear binders. We call these binders. In a way, they look like sports bras. They're not necessarily the same thing. Some patients may actually use wraps or bandages, and this is really just trying to push down breast or chest tissue to give more of a typical male profile. Now, the main things that come up with binders, and people will say, well, are there any studies, right? And typically for many of these things, these aren't things that you'll see in guidelines or people are talking with their providers about, but certainly the community is using them. Some of these can be very expensive. People can purchase them online. And then others, people are just making do with things they have, like tapes or wraps, to give themselves curves and things like that. There actually was a study in transgender health in 2018 where they interviewed people using binders. And the main takeaway from that is like almost the entire population said that they had some kind of issue with their binder, some kind of medical issue, maybe skin irritation, or it's too tight, not fitting correctly, that was causing medical problems. but very few people actually felt comfortable talking to their provider about the problems that they were having, right? Because they didn't feel that it was safe, or they didn't feel that their provider would really understand or know how to even counsel them for the problems they were having. The next picture you see is an example of something that's called tucking. And so transfeminine patients will basically try to push the testicles up into the inguinal canal, and then tuck the penis or the shaft of the phallus backwards, right? Again, this is all trying to create a female contour. Again, no real studies out there, but our patients may have problems, right? So there might be pain with pushing the testicles into the inguinal canal. Also, what is the effect of the body heat on sperm? If that's something that's, if the patient's interested in fertility, certainly sperm can be affected. Also, tucking the penis backwards closer to the anus, right? We can see more infections. Also, we can also see people, because in order to urinate, you have to untuck and go through this whole process, removing tape, things like that. Patients may also be restricting how much they're drinking, so that they don't have to untuck to have to go to the bathroom. And again, we can see issues with urinary infections and other bladder problems there. And then these are some other examples of materials that patients may use to create curves and bulges in places, again, under clothing to try to support. And some of these can be extremely expensive. And then again, many patients are just being creative and creating their own ways. Another thing that providers need to be aware of is tape, right? So we want to make sure that if people are taping things, that they are medical tape or tape that allows the body breathing as much as possible, not things like duct tape, which can really rip up the skin. And also that people, if they have the ability, are taking breaks as much as possible. Even though that's not very affirming, these body parts can be very dysphoric for people, making sure that people have any breaks to allow the skin time to breathe. And of course, for many people, especially when they become the age of consent, making sure that they have access to surgical interventions, if that is what they desire, can also be very, very helpful, so that people don't feel that they have to, throughout their lifetimes, continue some of these interventions. There are some really wonderful resources, of course, WPATH. I'm also going to point out some of the US resources. I don't think these are solutions. Again, this is a US or Western population, but sometimes looking at certainly how some support groups or other organizations have done things, then you can take what makes sense for your population, right? And build off of that, especially if you feel like you're starting from scratch for some of these things. The beautiful Indian Standards of Care, which Dr. Sanjay and his colleagues have created, and you'll be learning much more about. In the United States, there are 2 organizations to support families and parents and patients that I feel are very, very good. Again, much of this is making sure that parents have connection with other parents and support, right? Because their child cannot teach them the things that they need to learn to be supportive of their children. They need to learn from other parents whose children have really thrived with access to interventions. And some of those organizations are Gender Spectrum and PFLAG, which classically, at least in the United States, was really a support group for parents and friends of lesbian and gay people. But a good 30 years later now, a lot of the work and support they're doing is really about supporting transgender and gender diverse families. Okay, and so the Indian Standards of Care, the main takeaways from today are early recognition. This care is very individualized. Always making sure with anyone we're working with to use respectful and affirmative language, avoid causing harm, right? We're not talking about punishment. We're not talking about trying to change our children's path, but just really meeting the child where they are and being supportive of wherever that path goes. Assessment of comorbidities, and again, support, especially with anyone under who's a young, an adolescent or prepubertal age. It's really about all those supports. Education, not just the patient, but of course the family and community, advocacy, the team approach, considering sociocultural, legal factors, facilitating that social transition as early as possible for when your patient is identifying and what makes sense to best support that patient. And of course, proper and timely referrals for interventions. And I want to end my talk today by circling back to Iran, right, who really has been a leader in your country for the community. And what's interesting is for Iran and Lakshmi, when the pandemic started and everything shut down, Iran immediately recognized that many trans men were actually, they could only get their testosterone shots in clinics. And while for many in the trans feminine community, they had access to the families and the homes that they lived with, their created communities, to still continue their hormones and their medical care. Many trans men did not. And so Iran actually and his partner Lakshmi created a network in the first 3 months of COVID to really bring medication. Sometimes I think some communities he was visiting were hours away, bringing people injections and medications, creating a community network that trans men didn't classically have. And so this just really speaks to the resilience of these beautiful young adults in these communities. And when given support or even just given a window, they can thrive. And the amazing things that this community can do to help itself. Another thing to remember with the COVID lockdown is that many of young adults and young people who had found these chosen communities to help support them and affirm them had to return to non-supportive families and homes in different areas with the lockdown. And so that's something that's really important. And I think we're seeing this in every country now that we're, a year and a half, 2 years into this pandemic, that this isn't just access to hormones or medical treatment, but this is actually people are having to return to the very communities that shun them and ostracize them, and how I think the mental toll and the disparities that we will see once again increasing, unfortunately, because of, it's not just COVID, it's all the effects that this has on people, especially when they can't be in affirming places. Okay, so I'm going to stop my talk now. I hope I didn't go too long, Dr. Sanjay, and we'll go ahead from there.
Thank you so much, Dr. Jana. That was incredibly informative. And funnily enough, we don't have any questions because you one by one just knocked every single possible query that we could have had. So I think on that regard, this was one of the most comprehensive presentations that at least I know I've ever seen this thing on something like this. It was incredible. Next we're going to be moving on to Mr. Atul, who is over here representing two very distinct groups. Mr. Atul is not only a parent, he's also an educationist, and he's also representing parent support groups and the importance of parent support groups and the parents, because ultimately a trans child does not only go through this journey by themselves, it's also the parents' journey. And parents act as a bridge, between the child and the rest of society, a bridge between everybody who's over here and the people that they are seeking to provide care to. So I think, no more interjections from me. I'm going to hand it over directly to Mr. Atul. Sir, please take it away.
Thank you, Tia. I'm still recovering from the amount of information we've received from the previous presentation. Now, it was wonderful. It was an education that many people will receive in their entire lifetime, perhaps. So amazing presentation. And what I'm going to talk about is, something, in fact, every presenter has already emphasized, and that is the role of parents and their support groups. Now, every presenter so far has already said the role of families, the role of parents is extremely important, extremely critical. And this is where parents support groups become very critical. There are lots of gaps when it comes to the care that transgender young individuals require. The very first gap is the gap between the parents and the children. The moment a child comes out to a parent saying they are not comfortable with the gender assigned at birth, and they are actually the opposite gender, the first thing that a parent thinks of is that perhaps my child is misguided, they're in the wrong company, the social media is making them be this way, etc., etc., etc. Whereas in reality, the child has given it thought a million times and mustered up the courage to come out to the parents. And here is the parent thinking that perhaps this is happening because of the influence of social media. There are propaganda sites on the internet which tell parents that it is a social contagion, and parents can be so easily misguided into flowing down that stream. So the first big gap that we as members of parents support group can bridge is the gap between the children and their parents. When parents are able to talk to others who have gone through a certain journey and understand that this is not a social contagion, it is not a disease that can be cured, they start to really realize that their child needs different kind of help. It's not as if the child is delusional or something. Now, that's the first gap. That's the first gap that we, as members of the parent support group, can help bridge. And the most important thing we can do here is, we can stand out in the society as out and proud parents, so that parents who are getting started on this journey are able to approach us and talk to us and learn from the journey that we have gone through. The other gap that needs bridging is also the gap between these families and the medical health care providers. The advantage of having a lived experience that we all have is so useful for families and also the healthcare providers. The reason being that, when healthcare providers, for instance, the very first healthcare provider that a child should be taken to is a counselor, is a mental health professional. Now, there are going to be gaps here. There are going to be gaps here that need bridging, and the parent support groups can be so critical in bridging those gaps. Very often, parents themselves need counseling, and we, as members of parent support group, counsel parents to the extent that we can. But of course, we try to guide them and take them to proper professionals, counselors, mental health professionals who can provide the help that parents and children both need. So the role that we play, of course, in bringing up children is very, very, very critical, of course. But the role of parent support group in bridging the gaps between mental health professionals and the families, endocrinologists and the families, and the surgeons and the families, explain the need for certain procedures, explain the need for hormones, for instance. All those needs are better understood by children, their parents, when there are others who have the lived experience, explaining it to them and helping them understand the needs of the children, and also the need for medical procedures that these children need to go through. So we can play a very interesting and very useful role where as members of parent support group, we can bridge a whole lot of gaps. Also, we would like to perhaps act as watchdogs in certain scenarios. For instance, there is this abomination of this practice of doing forced surgeries on intersex children, for instance, before they are able to identify their own gender identity, and that's where we can help families understand the need to wait till the child is able to understand their own identity. They're able to express themselves confidently and clearly. The procedures need to be delayed till that happens. So that's the role we as members of the parent support group would like to play, and certainly I think that we need to play. So that's it from me here. Over to you.
Thank you so much, sir. Thank you so much. I'm gonna toss it right over to Prachi. Prachi.
Yes, sir. Sir, I think Mr. Atul's input is extremely important here, because we need to understand that looking at people in the gender dysphoria umbrella is not just necessary in medical fraternity to look at them as patients, but also as people. And Dr. Atul and Mr. Atul, with his personal anecdotes, his experiences of raising children and being a member of the parent support group, gives us a very essential, a very crucial link to understand gender dysphoria through a human rights lens, through the rights of a person who is actually dealing with the life of another person. And I think that is the takeaway lesson for today, that we all are human beings and we all deserve to have a life full of dignity and with basic human rights in general. So I think that concludes our lineup for all the speakers. However, we are not ending the session now. I am gladly handing it over to Dr. Sanjay Sharma, who will now deliver a vote of thanks and also has in mind a very special song that he wants to play for us. So over to you, Sanjay, sir.
Thank you, Prachi. And, I'm not going to waste anybody's time by saying thanks, because saying thanks is not going to help. How can I thank Dr. Gail for spending hours searching for the right people from who could come and educate you all? And how can I thank Dr. Wallace for stepping in at the nth moment and being there for us? And how can I thank Dr. Jenna for spending so much time and leaving us with a presentation which really we had no questions to ask, and very rarely have I seen that happen. And how can I thank Dr. Harish, who has supported us in this, who has given us this beautiful platform? And how can I thank Kurentia? I'm really not going to thank anybody. I'm just going to say this is something that we need to do. And this is not the the last webinar. This is just the second in the series. And we have another interesting webinar for you on the 5th of September. 5th of September, incidentally, is Teachers' Day. And what better day to do a webinar on than to have it on Teachers' Day, a great day for learning for all of us. And we are going to be addressing gender affirmative medical care and gender affirmative surgical care. Very important aspect of transgender health. So please block 5th September. There's going to be a subsequent webinar where we will be covering mental health. And again, what better day than to do it on the 10th of October, the World Day for Mental Health. So we cover mental health, we cover public health approach. We also have some interesting speak from the community. We also will be taking in some important talks from people from the government who will enlighten you on to what progress we are making towards the center of excellence. So that's it from me. And yes, there is a beautiful number that we're going to leave you with. And it just highlights how beginnings may be small, but they, with those little steps, we all get so stimulated and energized to take it to its conclusion. Do keep asking us questions. We have put our
Thank you so much, Sanjay sir. I understand that Dr. Gale, Dr. Wallace, and Dr. Jenna, we would just like to tell you what this means. It means when you move, India moves. And I think this is where we would like to tell you that we, all of us, we are the future leaders. And this cannot be justified any more than what we all are trying to do. And on an ending note, we would like to give this an open space, but we'd love to have everybody's cameras on because we wanted to take a group picture. So people, can we all have your cameras on? I'd like to give this opportunity over to Arshneet, who had a few words to say about Querencia, the future leaders, the people who move when India moves. So Arshneet, take it away. Meanwhile, let us have everybody's cameras on. Okay, Arshneet, can you unmute? Okay, no problem, no problem. I'll go ahead. So let us take a picture first and then we'll go. So I'm taking the picture, but we'd love someone else also to click along with me. There are 60 people in the audience, so we'll have to hold that pose. Okay, perfect, people. Smile. Done. So I think Arshneet, I'll go over to what you wanted to say. In November 2020, a group of Hardonians decided to come together and to educate each other as well as advocate for a more inclusive healthcare setting today and in the future. As future healthcare workers, it is our right as well as responsibility, because it was said such beautifully by one of our speakers that with this right also comes our responsibility. We are the medical students who rally for support for the LGBTQIA community internally as well as through our Instagram page. And we strongly believe that spreading awareness is the strongest tool at our disposal. We've all collectively walked this far, and we've had the pleasure of support of like an unending pillar of support from Dr. Harish Pemde, the director LHMC, Dr. Aparna ma'am, and Athi, Dr. Sanjay sir, Tia, and the entire team. We have shaped what is in front of you today, and our family is composed of 64 driven individuals who feel the need for bringing about a change in ourselves and thus the entire world. So when we walk, India walks, and from Independence Day, this is our takeaway, and I'm handing it over to our speakers for an open space where you all are free to say so. Dr. Pemde, Dr. Jenna, Dr. Wong, Dr. Sanjay, Dr. Gail, and Mr. Atul, Dr. Priya, and Dr. Kavita Arora, ma'am, we would love to hear from you.
Can I go first?
Yes, sir.
Woo-hoo.
I think that is enough.
Thank you so much, everyone, and thank you for inviting me to take part, and I look forward to participating in the next webinar.
Dr.
Oh,
Jenna.
thank you so much.
Well, thank you, everyone. What a pleasure. And this is, been so educational for me and preparing for this talk as well. And I also look forward to more participation. And Sanjay, you have my heart. It's been such a pleasure getting to meet you and know you and learn about your culture, your passion, and that just makes me even more excited to learn and participate as well. So thank you.
Thank you, Jenna. Thank you, Jenna. And Dr. Wallace.
Thank you so much for having me. I really love we have a chance to share this with diverse culture and different ethnic group, because transgender care is universal care. It's not just for one culture, one country only. Yes, it's more advanced in the Western culture at this point, but I hope that with the education and then with the share of knowledge, that we're able to provide, we all learn together with this regarding what cultural group or what country you come from. And I think that would be a good way to starting in places like this. Thank you.
Thank you so much. Thank you so much, everybody, for staying with us beyond the time that we had allotted for this webinar. And please block the date for the 5th. We promise you a good time on the 5th too. Thank you. I think with this, we will finally close. And I would request you all to do a collective woohoo, and that's it. That's it for us.
Ooh.
Goodbye. Goodbye. Good night.
Bye-bye. Good night.